All right, so picture this. You're walking down the street, maybe you're grabbing a coffee, and you see someone wearing one of those Velcro braces.
Yeah.
You know, the one strapped right below their elbow.
Yep. Tightly on.
What's the very first thing that pops into your head?
Oh, they play tennis. For sure. You
Yeah.
just assume they've got this wicked backhand and they've been overdoing it on the court.
Exactly. We see that brace, we hear the name tennis elbow, and our mind just immediately goes to Wimbledon. But the sources we're diving into today, a clinical script from Dr. Salem and the latest NHS guidelines, they suggest that's completely backwards.
It really is. I mean, the irony is that if you actually ask that person when they last held a tennis racket, they'd probably give you a funny look. Odds are, never.
So today we're doing a deep dive into lateral epicondylitis, which everyone just calls tennis elbow. But the mission here is not just to talk about a sore arm.
Right.
We're going to figure out why this thing has almost nothing to do with sports anymore and everything to do with how we live now.
It's really a story about office chairs, screwdrivers, DIY projects, and kind of surprisingly, smoking.
And we're going to get to the bottom of this huge misunderstanding about how we treat pain. Because if you think the answer to your elbow screaming at you is just to pop an ibuprofen, you might be barking up the completely wrong tree.
Worse than that, you might actually be slowing down your own recovery. We really need to talk about why the medical world is sort of quietly dropping the word inflammation from this whole diagnosis.
That was a huge moment for me in the reading. Plus, later on, we have this safety warning from the NHS that I can almost guarantee you have never heard before.
Oh, I know the one.
It involves painkillers, your skin, and open flanks.
It is wild. I actually had to double check that one myself, but it's legitimate.
We'll get there. But let's start at the beginning. If someone's listening to this and they're, rubbing their arm right now, what does this actually feel like?
It's a very specific feeling. This isn't some vague ache deep inside the joint. The NHS is really clear. It's pain on the outside of the elbow. And the intensity can be, well, anything from a mild annoyance to pain that literally keeps you up at night.
That sleep disturbing part, that really jumped out. It's that constant nagging throb that doesn't just switch off when you lie down.
Exactly. And the pain, it doesn't always stay put. It can radiate down your forearm toward the wrist. But the real giveaway, the functional part, is just not being able to straighten your arm without pain and this massive drop in your grip strength.
Which brings us to the anatomy.
Yeah,
Because to get why you suddenly can't open a jar, you have to understand the machinery, right?
that's the key. Most people think elbow pain means the hinge is broken or something. But the joint itself, where the bones meet, that's usually fine. This is a soft tissue problem. It's a tendon problem.
So we need to find the lateral epicondyle?
That's the one. It's just the fancy name for the bony bump on the outside of your elbow. If you bend your arm, it's that sharpest point. That bone is an anchor.
Okay, I've got it. An anchor for what?
It's the anchor for what's called the common extensor tendon. Now that sounds like a group of things, and it is, but there's one specific muscle in that bundle that's the villain in almost every single case.
Okay.
It's called the extensor carpi radialis brevis, or ECRB for short.
UCRB. Sounds like some kind of secret agency.
It might as well be. But here's the thing you need to picture to really get this. That ECRB muscle, it starts at your elbow, runs down your forearm, and it attaches to your hand. Its only job is to lift your wrist backwards.
So if I hold my hand out, palm down, like I'm about to type, and then I lift my knuckles up.
That's the ECRB firing. It's contracting, and every single time it contracts, it pulls on that anchor point up at your elbow.
Oh, wow. So even though the work is happening at the wrist, like typing or using a mouse, all the tension is being felt way up at the elbow.
Precisely. It's a pulley system. You're working one end, but the rope is starting to fray at the anchor.
And that seems to be the biggest aha moment from Dr. Salem's notes, the whole fraying rope idea. Because for years we heard epicondylitis, and that suffix, itis, that means inflammation.
Right. We hear etitis and we think
Fire.
fire, heat, swelling. You picture all these white blood cells rushing to the scene to fight something off.
So you treat it like a fire, you put ice on it, you take anti-inflammatories.
But here's the twist. Dr. Salem makes it very clear that when you actually look at the tissue from a chronic tennis elbow patient under a microscope, there are basically no inflammatory cells there. It's not a fire, it's what we call a degenerative tendinosis.
Okay, etios is not etiditis. So what's the difference between a tendon that's inflamed and one that's degenerating?
Think of inflammation as an active battle. The body's trying to fix something right now. But degeneration, that's like an old rubber band that's been stretched too many times. It's structural failure. The material itself is breaking down.
It's losing its integrity.
Exactly. The medical term for it is a failed healing response. You get these tiny little micro traumas from overuse. Your body tries to fix them, but you just keep doing the activity so it can't keep up. The collagen fibers, which should be lined up perfectly straight, like uncooked spaghetti.
They become a complete mess.
They look like cooked spaghetti, just
Yeah.
a tangled, weak jumble that can't handle any load.
And the notes also mention something called neovascularization. Neo is new. Vascular is blood vessels. That sounds like it should be a good thing, right?
You'd think so, but it's actually a sign of panic. The body sees the tendon tissue is dying from stress, so it tries to grow these new, tiny blood vessels into it to save it. But these vessels are abnormal, and crucially, they bring nerve endings with them.
Wait, so the body grows nerves into the damaged area?
Yes, nerves where they shouldn't be, which is a huge reason why it hurts so much. You're literally growing pain receptors into a spot that's falling apart.
That's a huge insight. So if the problem isn't inflammation, but this messy collagen and a crumbling structure, then taking anti-inflammatories is like trying to fix a crumbling wall by spraying it with a fire hose.
You're treating the wrong process, exactly.
It explains why people have this for months or even years. They're treating a fire that isn't even there.
And you're not fixing the collagen by taking a pill.
So, who is actually getting this?
Mhm.
If it's not tennis players, who is it?
The demographic is so consistent. The peak age is between 35 and 55.
Prime career age. The getting things done years.
It is. And the activities are anything with repetitive wrist extension. The number one modern culprit, the computer mouse.
It's just the clicking.
It's the whole posture. Think about your hand on a mouse. Your wrist is usually bent back just a little bit, right? Just hovering. That means the ECRB muscle is slightly contracted, holding your hand up for 8 hours a day.
It's under constant low-level tension.
Constant. And that's before you even start clicking. But it's not just desk jobs. It's tradespeople, plumbers, carpenters, anyone using a screwdriver. Dr. Salem's notes even list things like lifting a heavy kettle.
That is so mundane. It's the injury of just existing in a house.
It is, and often it's the weekend warrior thing. You sit at a desk all week, so your tendon is weak, and then on Saturday you suddenly decide to paint the whole house. Your tendon just isn't conditioned for that sudden load.
Speaking of things that affect conditioning, there was one risk factor that really surprised me. Smoking.
Yeah, it sounds totally unrelated, doesn't it? But remember, this is a failed healing condition. Tendons already have a pretty terrible blood supply.
Right.
Well, nicotine is a vasoconstrictor. It shrinks your blood vessels. So if you smoke, you are taking an area that already has poor circulation and you're choking it off even more.
So the smoker's elbow just never gets a chance to rebuild itself.
It's starving the tissue of what it needs to repair those micro tears. It makes the failed healing almost inevitable.
Okay, let's get practical. Let's say I'm 40, I work at a desk, painted my fence, now my elbow hurts. I go to my doctor. Do I need an MRI?
Generally, no.
Yeah.
Which is good news. Dr. Salem is clear this is a clinical diagnosis. That means a doctor can figure it out just by talking to you and having you move your arm. No expensive imaging needed.
So what are they looking for?
Well, first, the classic signs. Pain when you grip things, pain when you twist something, like opening a jar. Shaking hands can be agony.
And the physical tests. Can we do these now?
You can, but just be careful. The first is simple tenderness. Just press on that bony bump on the outside of your elbow. If that's really tender, that's a big sign.
Okay.
Then there's something called Cozen's test. You sit down, put your arm out straight, make a fist, and then try to bend your wrist back like you're revving a motorcycle.
Right.
But you use your other hand to push down and resist that movement. If that recreates the sharp pain in your elbow, that's a positive test.
Oh, is it ever? Tennis elbow. Can it be something else?
Yes, and this is a tricky one. The sources warn about something called cervical radiculopathy. Basically, a pinched nerve in your neck.
A neck problem causing elbow pain.
Yes. The C6 nerve root in your neck travels all the way down your arm, and it supplies the sensation right on the outside of your elbow. So the problem could be your neck, but your elbow is the one screaming about it.
That's terrifying. You could spend months treating your elbow and get nowhere because the signal's coming from somewhere else entirely.
Which is why a good clinician will always check your neck range of motion, too.
Okay, so let's assume it's definitely the elbow. The rope is frayed. How do we fix it? What does the NHS recommend for home care?
The first step is the hardest one, modification. You have to stop doing the thing that's causing the strain If it's your mouse, you need an ergonomic mouse or you need to switch hands for a while.
Switch hands. That sounds like a disaster for my productivity.
It's awkward for a week, but you have to reduce the load to let the healing start.
The NHS also mentions ice, rest them, all
Yeah.
usual stuff.
Yeah, and ice is good for pain management. It'll numb the area. But just remember what we said. It's not actually curing the degeneration. It's just an analgesic.
Right. Now we have to talk about the gel. I teased this earlier, but I genuinely couldn't believe this when I read it in the NHS guide.
The ibuprofen gel warning, yeah.
It says, and I'm quoting this, do not smoke or go near naked flames. There is a risk of severe burns.
It sounds totally made up, doesn't it? But it's true. A lot of those topical gels use alcohol or other flammable solvents to help the drug get through your skin. So you are essentially slathering your arm in fuel.
So your arm becomes a candle wick.
If you don't let it dry properly and you light a cigarette or lean over a gas stove,
Yeah.
yes, there have been actual reported cases of it catching fire.
That is just unbelievable. My elbow feels better, but my sleeve is on fire.
It's a very specific risk, but a serious one. So, let it dry.
Good advice. Okay, so if pills and ice are just masking the pain, what's the real solution? How do you actually repair the tendon? How do we comb out that cooked spaghetti?
This is the absolute cornerstone of treatment, and it's where most people fail because it's slow and it's boring. The answer is specific exercises. It's called eccentric strengthening.
Eccentric, so not like quirky exercises.
No, in biomechanics, it means lengthening under tension. So think of a bicep curl. Lifting the weight up is concentric, but lowering it back down slowly, that's eccentric. The muscle is working, but it's getting longer.
Okay, I think.
And research shows that this specific type of loading is what tells the tendon cells to wake up and start laying down new organized collagen. It's like you're mechanically signaling the tissue to repair itself properly.
So how would you do that for your elbow?
You sit at a table, rest your forearm on it with your hand hanging off the edge. You hold a light weight like a can of soup.
Okay.
You use your good hand to lift the weight up into that rev the motorcycle position so the bad arm does no work on the way up.
Right.
Then you let go with the good hand and you use your sore arm to very, very slowly lower the weight back down.
Up with two hands, down with one.
Exactly. You focus only on that controlled lengthening. But this isn't a quick fix. We're talking 3 sets of 15 reps twice a day for maybe 12 weeks.
That's a huge commitment.
It is, but it's the only thing that really fixes the root cause, the structural weakness.
What about those braces, the straps people wear?
They're useful, but they're a crutch. They work by creating a kind of fake ankle point for the muscle, so it takes the tension off the actual injury site.
So it reduces the pain while you're working.
Yes, but it doesn't fix the tendon. If you rely on the brace and stop doing the exercises, you're just masking the problem.
Okay, we have to talk about the magic shot. The cortisone injection. I know people who swear by it.
The steroid injection, this is the most controversial part of the modern guidelines. Dr. Salem's script is very, very cautious about this.
Why? If it gets rid of the pain, isn't that a win?
It's a short-term win for what can be a long-term loss. Steroids are incredibly powerful. They shut down pain signals. So for 4 to 6 weeks, you feel fantastic. You think you're cured.
I sense a but coming.
But the studies are pretty clear. People who get steroid shots have much higher recurrence rates a year later than people who just did physiotherapy, or even people who did nothing at all.
Wait, people who did nothing fared better than people who got the shot.
In many long-term studies, yes. The theory is that the steroid might actually harm the tendon cells. And because the pain is gone, you go right back to your old activities.
And re-injure the weak tendon without even knowing it.
Exactly. You've silenced the alarm bell, but the house is still on fire. The guidance now is to only use it if the pain is so bad you can't sleep or do the rehab. It's a bridge to get you to physiotherapy. It's not the destination itself.
And what about surgery?
It's the absolute last resort. We're talking less than 5% of cases, and only after 6 to 12 months of trying, everything else has failed.
That timeline is the hard part to accept, isn't it? 6 to 12 months.
It is. We want next day delivery on healing. But tendons heal on their own schedule, and it's a slow one.
So the prognosis is good, but slow.
Very good. 80 to 90% of people get better, but you have to be patient. If you're 2 months in and it still hurts, that's completely normal. You have to stick with it.
So to bring this all home, let's just recap the big takeaways.
Let's do it.
First, forget the name. It's probably mouse elbow, not tennis elbow.
Right. It's from your daily habits.
Second, it's not a fire. It's a frayed rope. It's degeneration, not inflammation. So popping Advil isn't the real fix.
And that's why the exercises are non-negotiable. You have to rebuild that rope.
Third, Be very wary of the quick fix, especially that steroid shot. And fourth, let your elbow gel dry before you go near the stove.
Please, the most important safety tip we have: do not combust.
It really makes you think, though. We call these things injuries, but hearing you talk about the failed healing response, it feels more like a warning light from our own bodies.
That's a perfect way to put it. Which brings up a final, bigger thought. If tennis elbow is really a sign that our bodies can't keep up with our modern, repetitive lifestyles, what other common aches and pains are we mislabeling? What other things that we call injuries are actually just our bodies protesting the unnatural, repetitive way we ask them to move every single day?
Our bodies protesting the boredom of our mechanics.
Exactly. It's a design flaw in modern life, not just a weakness in your arm.
On that note, I think I'm going to go do some eccentric wrist drops.
A very good plan.
Thanks for diving deep with us. Hopefully your elbows feel a little less mysterious now.
Patience in physio.
See you on the next deep dive.